Hello, welcome to the course Klinefelter Syndrome, Identifying, Characterizing, and Managing an Underdiagnosed Condition with Serious Consequences. Today we're covering Lesson 3, Physical and Mental Comorbidities. This is a CME course from AXYS, the Association for X and Y Variations, at genetic.org. My name is David Hong. I'm a faculty member in Psychiatry and Behavioral Sciences at the Stanford University School of Medicine. The overall course covers a number of topics around Klinefelter syndrome, and today we're going to focus on identifying and discussing the physical and mental health comorbidities commonly found within Klinefelter syndrome. Indeed, there are a number of significant comorbidities that are commonly identified in adult men with Klinefelter syndrome relative to men who don't have Klinefelter syndrome. This includes a twofold increased risk of cardiovascular and cerebrovascular disease. There's also a 4 to 6-fold higher risk for type 2 diabetes, as well as an 8-fold increased risk for disorders of the bone such as osteoporosis and osteopenia. Lastly, there's a 4 to 8-fold increased risk for venous thrombosis. It is important to note when discussing the frequency of comorbidities in KS that up to 60 to 75% of men with Klinefelter syndrome never receive a formal diagnosis. This particular course reflects currently known frequencies of comorbidities as observed in ascertained individuals in prior clinical research. As such, the literature reflects a mixture of men and individuals who have been referred for a clinical syndrome, as well as individuals who have received a diagnosis prior to the manifestation of any clinical symptoms. Together, this may have differing levels of ascertainment bias in our currently known estimates. Therefore, future studies may identify different rates of comorbid conditions once prenatal screening becomes more widespread, and as we become closer to identifying the natural incidence of XXY karyotypes across the larger population. Moving on to discuss some of these comorbidities, one is metabolic syndrome and related conditions. Up to 50% of individuals with Klinefelter syndrome will have metabolic syndrome. This means having at least 3 of the following 5 symptoms: hypertension, low HDL, elevated triglycerides, abdominal obesity, and glucose intolerance. Notably, 20% of individuals eventually develop type 2 diabetes. There's also increased incidence of hyperlipidemia, particularly hypertriglyceridemia, insulin resistance, hyperinsulinemia, and fatty liver disease. Relatedly, adults with KS often have increased weight, hip and waist circumference, total and abdominal fat mass, as well as total fat percentage. The underlying cause of abdominal obesity, increased insulin resistance, and related metabolic issues is still unclear. It should be noted that even thin and normal weight adults with Klinefelter syndrome may still develop metabolic syndrome. The link between low serum testosterone levels with abdominal obesity and metabolic syndrome is already well established in men independent of KS, and therefore is believed to play an important role in these conditions within KS, which is often characterized by hypogonadism. This abdominal adiposity in KS begins during puberty, and research believe other factors also likely contribute to this process in the population. Regarding the potential genetic etiologies that may be involved in increased abdominal fat mass in KS, theories include overexpression of X-linked genes within the 47XXY karyotype, skewed X chromosome inactivation of the second X chromosome, transcriptional dysregulation of the apoptosis cascade, changes in transcription of glucose metabolism and inflammation genes, polymorphism, including a CAG repeat difference within the androgen receptor gene, abnormal production of the chemokine CCL2, which is involved in the inflammatory pathway. Insulin resistance is likely related to factors beyond obesity, including etiologies such as gene dosage effects of the CSF2RA gene, which is present on the X and Y chromosomes, presence of higher leptin levels, overproduction of the chemokine CCL2, which is related to inflammation, increased platelet reactivity, as well as methylation and RNA transcription changes in the KS genome. Testosterone replacement therapy, or TRT, is a mainstay of treatment in KS. It reduces fat mass, increases muscle mass, and improves glycemic and insulin sensitivity. In a recent randomized double-blind placebo-controlled study of 20 adults with KS, it was demonstrated that 6 months of testosterone therapy reduced abdominal fat mass and total body fat. TRT did not affect glucose homeostasis or other measures of intermediate metabolism. However, the study's authors hypothesized that continued reductions in fat mass over time would eventually lead to increased insulin sensitivity. Venous diseases show that there is greater risk of clotting disorders in KS. Varicose veins are present in up to 20% of individuals and are often severe and early in onset. Venous ulcers demonstrate a 10 to 20-fold increased risk, and venous thromboembolism is also increased. A Swedish cohort study of adults with KS found a cumulative incidence of VTE of 8.6% at age 50 and 20.8% at age 70. Another study found that the risks of pulmonary embolism and deep vein thrombosis were 5 to 20 times higher in individuals with KS compared to adults without KS. Epidemiological studies have also confirmed that individuals with KS have a 4 to 8-fold higher incidence of venous thrombosis. One study found an especially high relative risk for VTE in adults with KS who are less than 30 years of age, and in those of 30 to 49 years of age, thereby linking VTE to increased risk of death at a young age. From an etiological standpoint, thrombotic events in KS are likely linked to hypogonadism as well as to the treatment, TRT. Increased platelet reactivity has been found in adults with KS and is thought to play a role in this increased thrombotic risk. Similarly, the higher incidence of type 2 diabetes and metabolic syndrome, both of which independently increase thrombotic risk, may also be additional risk factors. Other theories regarding the underlying cause of increased thrombotic risk in adults with KS include an imbalance between thrombosis and homeostasis and vascular abnormalities. TRT itself has an independent effect on thrombosis risk. On the one hand, it may offer protection against thrombosis by stimulating synthesis of coagulation inhibitors. On the other hand, it may raise thrombotic risk by increasing thrombin generation. Clinically, as TRT often increases hematocrit, HCT should be checked twice yearly. If found to be 48% or higher, it is recommended to correct by lowering TRT dose or bleeding through blood donation to reduce the chance of thrombotic events. Structural and functional cardiovascular abnormalities are also found to be at higher incidence in KS. These include left ventricular diastolic dysfunction, mitral valve prolapse, increased thickness of the inner layer of the carotid arteries, the tunica intima, and shorter QTc intervals. Adults with KS are found to have fewer circulating endothelial progenitor cells, EPCs, which is linked to atherosclerotic progress and morbidity and mortality from cardiovascular disease. TRT was not found to improve this clinical outcome. Abnormalities such as shorter QTc intervals may be related to genes on the X chromosome and the modulating effect of testosterone, while other abnormalities may be related to other comorbidities such as metabolic syndrome. Impaired exercise tolerance is also noted in Klinefelter syndrome. This is a relationship between lower muscle mass, reduced VO2 max or maximal oxygen uptake, which means the reduced peak oxygen uptake during exercise, and CI or chronotropic incompetence. Overall, a lower proportion of predicted maximum heart rate and lower increase in heart rate from baseline to exercise states. CI causes exercise intolerance and has a large impact on quality of life and is a major predictor of major cardiovascular disease. Regarding cancer, the overall risk for cancer is not higher relative to the general population. However, there is increased risks within specific types of cancer, such as breast cancer. In fact, Klinefelter syndrome is the strongest independent risk factor for breast cancer in men. Men with Klinefelter syndrome have up to a 30-fold higher risk of breast cancer. They also appear to be diagnosed at younger ages. Regarding extragonadal germ cell tumors, epidemiological and pathology-based studies show a marked increased occurrence of these rare tumors, which develop in the midline. Because these cancers are rare overall, there are no formal clinical recommendations for screening in asymptomatic individuals. Evidence of a link between KS and other cancers such as leukemia and non-Hodgkin's lymphoma also exists. However, the data hasn't been clear enough to establish a direct association at this time. Regarding diseases of the bone, osteoporosis and osteopenia have found to be at 8-fold higher incidence in KS. There is also a higher incidence of fractures, and mortality associated with femur fractures have been observed in KS as well. This might be the result of reduced bone mineral density in the lumbar spine, femoral neck, and hip in particular. It is thought that appropriate TRT will reduce the incidence of both of these conditions. Immune disorders are also increased comorbidity in KS. Large registry studies from the United Kingdom and Denmark have shown that adults with KS have an increased prevalence of the following autoimmune conditions: Addison disease, type 1 diabetes, hypothyroidism, rheumatoid arthritis, Sjogren's syndrome, and systemic lupus erythematosus. Researchers have not yet identified specific genes or genetic mechanisms that cause this increased risk of autoimmune disease, but it is believed that it's likely due to dosage effects of genes on the extra X chromosome. Dental issues are also a common comorbidity identified, with 40% incidence of taurodontism. This is a rare disorder consisting of enlarged pulp and a thinning surface of the tooth, causing premature tooth decay. The overall incidence in the general population is less than 3%. Mental health comorbidities are also frequently identified in KS. This higher incidence of mental health issues relative to individuals without a KS karyotype includes psychiatric diagnoses, learning challenges, and personality and temperament traits. Individuals with KS are found to be 3 times more likely to be hospitalized with a psychiatric disorder based on epidemiological surveys. Regarding brain function and structure, as found in neuroimaging studies, a cumulative assessment of the prior literature shows that there are consistently reported volume differences in the brain between men with Klinefelter syndrome and individuals with a 46XY karyotype. This includes global measurements, such as evidence that there is decreased total brain volume, as well as the subcomponents of decreased gray matter volume and white matter volume in individuals with KS, as well as specific regions showing decreased brain volume. This includes the insula and striatum and the amygdala, a network of regions associated with social cognition and emotion processing, the hippocampus, a structure associated with memory, the frontal and prefrontal lobes, which is implicated in executive functions, and the temporal lobe, which plays a large role in language processing. Men with KS are also found to have increased total ventricle volume, as well as increased volume in a specific region of the occipital lobe, which is a visual area. In addition to these structural studies, functional imaging studies, or fMRI, demonstrate activation patterns, as well as cerebral perfusion studies, which show that during verbal tasks, there is functional lateralization of language-related ability to the left hemisphere in typical brain development, which may not be evident in individuals with KS. Within a neurodevelopmental framework, there are a number of conditions that have also been identified as frequently being comorbid in KS. This includes findings that individuals with XXY are at increased risk for having issues with attention, distractibility, impulse control, hyperactivity, repetitive speech or movements, and issues with social communication or social interaction. These cognitive and behavioral traits may also increase the chance of an individual with XXY receiving a diagnosis of clinical attention deficit hyperactivity disorder or autism spectrum disorder compared to individuals with the typical XY karyotype. It is important to recognize that when these psychiatric diagnoses are made, they may not represent a separate condition or a classical diagnosis of ADHD or ASD, but rather may represent elements of the overall spectrum of potential symptoms associated with XXY. Digging deeper into the social, emotional, and cognitive issues, there is evidence that difficulties with executive function may include working memory, flexible thinking, organizational skills, and self-control. Studies have also identified lower levels of extroversion, conscientiousness, and openness to experience. However, a recent study showed no difference in the level of these characteristics between adults with KS who had received testosterone therapy and those who remained untreated. Clinically, however, there is an impression that testosterone treatment may lead to better neurocognitive functioning. However, future studies are still needed to clarify this point, and there are a number of ongoing studies in this area in developing youth, examining neurocognitive outcomes with TRT. Mood and anxiety disorders are also likely increased in KS. This includes increased risk for generalized anxiety disorder in studies of youth and adolescents. Findings showed that rates of GAD or generalized anxiety is as high as 12 to 18% in boys with KS. This is in comparison to the general population where generalized anxiety might occur at 3 to 4% overall. Depressive symptoms are also increased, with one study showing that up to 70% report some or any type of depressive symptom at all. And an actual diagnosis of major depressive disorder is also increased at a rate of 14 to 24% incidence in adults and adolescents who met this criteria. That concludes this portion of this course. Please find these references available if you'd like to explore more deeply some of the issues that were raised in this module.